So we'll start. Sorry, uh, not responding to controls. 1 minute, I'm coming. Hold on a minute.
All right, well, with you.
Yeah, suddenly didn't respond to. All right. Okay. Hopefully it will work this time. So these are the table of contents. We'll start with a brief introduction. The ECG is a record of the electrical activity of the heart, as we all know. It is important in providing a diagnostic regular medical practice. So an ECG or electrocardiogram is the activity of the heart muscle as it changes with time, usually printed on paper for easier analysis. Like other muscles, cardiac muscle contracts in response to electrical depolarization of the muscle cells. It is the sum of this electrical activity when amplified and recorded for just a few seconds that we know as an ECG or electrocardiogram. Brief indications for the ECG or electrocardiogram: investigating possible cardiac abnormalities, investigating causes of syncope, investigating chest pain, investigating possible drug toxicities, and finally showing or demonstrating signs of metabolic disorders and electrolyte disorders. Before we go on, it's very important that we understand the heart's electrophysiology or the physiology of the electrical activity of the heart. The normal cardiac cycle, as we all know, begins with spontaneous depolarization of the sinus node, an area of specialized tissue situated in the high right atrium. This way, it produces a wave of electrical depolarization which spreads across the intraatrial septum to the left atrium. The atria are separated from the ventricles by an electrically inert fibrous ring. So essentially, in the normal heart, the only way that the depolarization wave can travel from the atria to the ventricles is through the atrioventricular node. The atrioventricular node delays this electrical signal for a short time, and then the wave of depolarization spreads down the intraventricular septum via the bundle of His and the right and left bundle branches into the right and left ventricles, which initiates contractions, which is important in maximizing cardiac efficiency and making the heart pump blood all across the body. And after complete depolarization of the heart, the myocardium then must repolarize before it can be ready to depolarize again for the next cardiac cycle. This is a diagrammatic view of what I was just saying. We have the sinus node, which depolarizes both the right and left atrium, and through the AV nodes, depolarizes the right ventricle and the left ventricle, initiating contraction and enabling the heart to work as it does. Now, the leads of the electrocardiogram or electrocardiogram. By convention, we record the standard surface ECG using 12 different recording lead directions. Thus, we have 12 different leads. But rather confusingly, there are only 10 recording electrodes. The electrodes are what we attach directly to the body on the skin, are required to achieve this. 6 of these are recorded from the chest overlying the heart, the chest or precordial leads. 4 are recorded from the limb leads. It's essential that each of the 10 recording electrodes are placed in their correct position. Otherwise, the appearance of the ECG will be changed significantly, preventing correct interpretation. So once again, the leads, there are 3 bipolar leads. That's 1, 2, and 3. 3 unipolar leads, the augmented right, augmented left, AVF lead, and the 6 precordial leads, V1 to V6. And then this is a diagram showing the limb lead placement. Just to quickly revise, we connect the lead wires to the electrodes. The tip of each lead wire is lettered and color coded for easy identification. The red or RA lead wire goes to the right arm. The yellow goes or LA lead goes to the left arm. The black or or neutral or neutral lead wire goes to the right leg. The green or left leg lead wire goes to the left leg. And then the chest lead placements, we have V1, red lead, which goes to the fourth intercostal space to the right of the sternum. V2, yellow lead, fourth intercostal space to the left of the sternum. V3, green lead, midway between V2 and V4. V4, brown lead, fifth intercostal space at the mid-clavicular line. V5, black lead, anterior axillary line at the same level as V4. And V6, violet lead, mid-axillary line at the same level as V4 and V5. Once again, that's another diagram showing what we've just discussed. Now, each of the leads has a view of the heart that it takes into consideration. The inferior portion of the heart is represented by the recordings from leads 2, 3, and ABF. The lateral view of the heart is shown by the recordings on leads 1, augmented left, V5 and V6. Anterior is shown by the third and the fourth, V3 and V4, while the septal portion of the heart is shown by V1 and V2. This is a diagram of a 12-lead ECG showing what I've just discussed so far. So ECG waves and intervals. We'll be discussing them in some detail as time goes on. And this is the P wave here, the PR interval, the QRS complex, the QT interval, the ST segments, the T wave, the U wave, the RR interval, the TP segments. P wave, the ECG waves are as follows. The P wave shows the depolarization of the right and left atria. QRX complex, right and left ventricular depolarization. STT wave, ventricular repolarization. U wave, the origin of the wave is not clear, but probably represents after depolarizations in the ventricles. PR interval, time interval from onset of atrial depolarization, P wave, to onset of ventricular depolarization, that's at the QRS complex. The QRS duration is the duration of ventricular muscle depolarization. QT interval, duration of ventricular depolarization and repolarization. RR, the interval between two RR waves is the duration of the ventricular cardiac cycle and an indicator of the ventricular rate. TPP interval, the interval between two P waves, two consecutive P waves, the duration of the atrial cycle, which is an indicator of the atrial rate. And each of the intervals lasts for some time. The heart rate is between 60 to 100 beats per minute. The PR interval is usually between 0.12 to 0.20 seconds. QRS interval is less than 0.12 seconds. QT interval is less than half of the seconds. Females less than 0.44 seconds, corrected. We'll come to that later. The P wave amplitude in lead 2 is greater than or equal to 3 megavolt or millimeters. P wave terminal negative deflection in lead V1 is less than or equal to 1 millivolts. And then the Q wave is usually less than 0.04 seconds and 1/3 of the R wave amplitude in the same interval. Now, how to read the ECG? In general, we follow the rules of 4. You start by noting the 4 initial features: history, that's the clinical history of the patient, the rates as calculated from the ECG, the rhythm and the axis also as calculated from the ECG. You then look at the 4 waves, P, QRS, T, and U, and the 4 intervals, PR, QRS, ST, and QT. Once again, the 4 initial features: the history, the rates, the rhythm, and the axis. The 4 waves, P, QRS, T, and U, and the 4 intervals, PR, QRS, ST, QT. Now, the ECG paper is a grid where time is measured along the horizontal axis, with each small square being 1 millimeter in length and representing 0.04 seconds. Each large square is 5 millimeters in length and represents 0.2 seconds. Voltage is measured along the vertical axis. 10 millimeters is equal to 1 millivolts in voltage. And that's a typical ECG square. As you can see, one of the big squares here represented here, and then which lasts 0.20 seconds. And each of the small squares is 0.04 seconds, and one of the big squares here is equal to 0.5 millivolts. Now to the rates. If a patient has a regular heart rhythm, we'll soon see what a regular heart rhythm is. Their heart rate can be calculated using the following method. Count the number of large squares present between one RR interval and divide 300 by this number to calculate the heart rate. So for example, assuming there are 4 large squares in an RR interval, 300 divided by 4 will give 75 beats per minute. This is it diagrammatically represented, but using a different, so in this case, there are 2 large squares. So we have 300 divided by 2, which gives 150 beats per minute. If a patient's heart rhythm is irregular, the first method of heart rate calculation doesn't work, as the RR interval differs significantly throughout the ECG because of the irregular rates. As a result, you need to apply a different measure, such as counting the number of complexes on the rhythm strip. Each rhythm strip is typically 10 seconds long. We multiply the number of complexes by 6, giving you the average number of complexes in 1 minute. Example, 10 complexes on a rhythm strip, 10 times 6 gives us 60 beats per minute. The normal heart rate is between 60 to 99 or 100 beats per minute. If it's less than 60, it's called bradycardia. Greater than 100 beats per minute, it's called tachycardia. Now, the ECG rhythm. A patient's heart rhythm can be regular or irregular. The irregular rhythms can either be regularly irregular, i.e. a recurrent pattern of irregularity, or irregularly irregular, i.e. completely disorganized. Now, to get the ECG rhythm, we should note that the leads 1, 2, AVF, and B1 require an inspection for an accurate interpretation of rhythm. It involves looking for 5 points when we are looking at those 4 leads. The presence or absence of regular P waves, duration of the QRS complex, whether it's narrow or wide, the correlation between P waves and QRS complexes, whether the rhythm is regular or irregular, and also, very importantly, the morphology of P waves. A regular rhythm ECG has regular P waves, each preceding a QRS complex in a regular rhythm. So a regular rhythm, there are regular P waves which each precedes a QRS complex in a regular rhythm. And a normal sinus rhythm demonstrates positive P waves in leads 1, 2, and AVF, suggesting a downward propagation of atrial activation from the SA node. These features also help in identifying if the arrhythmia is originating in the atrial ventricles. Many disorders are related, of course, to rhythm abnormalities. For example, in atrial fibrillation, no real P waves can be seen due to the very fast atrial activity, and only a few impulses get to the ventricles, making the rhythm irregularly irregular, meaning that there will be irregularly irregular narrow QRS complexes, and there are no discrete P waves in atrial fibrillation. To give an example, this is an example of an irregularly irregular heart rhythm. That's the atrial fibrillation. You can see that there are no P waves. There's a QRS complex T wave here, QRS complex, and you can see that the number of boxes are different per wave. Now, the P wave itself represents atrial depolarization. Of a P wave is 2.5 millimeters in leads 2 and or 3. The P wave is positive in 2 and AVF and biphasic in B1. And the P wave duration is shorter than 0.12 seconds and inverted in lead AVI. Left atrial enlargement is associated with the P wave being more than 1 small box deep. in lead V1 and a bifid P wave in lead 2 with a duration that is longer than 110 seconds. That's for left atrial enlargement. Right atrial enlargement is associated with a peaked P wave taller than 2.5 millimeters in the inferior leads and more than 1.5 millimeters tall in leads V1 and V2. This is an example of normal P waves, normal versus abnormal as diagrammatically represented. The PR interval incorporates the time from the depolarization of the sinus node to the onset of ventricular depolarization, as we said earlier. And it should be between 120 to 200 milliseconds. That's 3 to 5 small squares. The PR segment, the part of the PR interval, is the short isoelectric line between the end of the P wave to the beginning of the QRS complex. As we'll soon see, it is used as a baseline to evaluate elevation or depression of the ST segment. Now, variations in the PR interval can lead to various disorders. Long PR interval may indicate a first-degree heart block as well as the second or a third-degree heart block. Short interval may be present in conditions with accelerated atrioventricular AV conduction, such as the presence of a bypass tract or with Parkinson-White syndrome and Lone-Ganon-Levine syndrome. To briefly explain, in addition to the normal tract between the sinoatrial and atrioventricular nodes, there are additional pathways there are additional pathways in some patients, which is usually due to a congenital problem most of the time, which can lead to premature conduction of electrical rhythms through these pathways, which can cause classic pictures on the ECG. More on that later. Now, the first degree heart block, as we know, represents prolonged conduction in the AV node. There's a prolonged PR interval. P waves and QRS complexes are normal, and the block is most often at the level of the AV node, hence the prolonged PR interval. Second degree heart block type 1. Typical ECG findings in type 1 block include progressive prolongation of the PR interval until the atrial impulse is not conducted and there's a dropped QRS complex. That's due to the fact that the rhythm finds it difficult to pass through the AV node, and this constant repeated conduction gets increasingly difficult until in the end there's a complete block, and the QRS complex indicating ventricular depolarization doesn't happen. AV nodal conduction resumes with the next beat, and the cycle repeats itself again. Type 2 is also known as a Mobitz or second degree AV block or a Mobitz type 2A block. That includes a consistent PR interval duration with intermittently dropped QRS complexes due to a failure of conduction. It's the same problem, only this time there's an intermittent drop in the QRS complex. The intermittent dropping of the QRS complex typically follows a repeating cycle. This is not seen in type 1. So it happens every third or fourth P wave. Hence a 3-in-1 block or a 4-in-1 block. Third degree or a complete atrioventricular block occurs when there is no electrical communication between the atria and ventricles due to a complete failure of conduction. As a result, there is no association between the P waves and the QRS complex. The atria and the ventricles are completely functioning independently of each other. Cardiac function is maintained by a junctional or ventricular pacemaker. There may be some narrow, complex escape rhythms originating above the bifurcation of the bundle of His and broad complex below the bundle of His. In other words, where there's a lot of ventricular depolarization is being activated all over the place. Basically, the pacemaker isn't no longer in the sinoatrial node per se. So these are diagrammatic representation of first degree heart block. The second degree heart block, you can see the type 2 where there's a dropped QRS complex. And then the third degree heart block where the PRS waves just happen independent of the QRST complexes. If the PR wave interval is shortened, it can mean one of two things. that the P wave is originating from somewhere closer to the atrioventricular node, so the conduction takes less time, or the atrial impulse is getting to the ventricle by faster shortcut, an accessory pathway, which is associated with a delta wave, which is seen, for example, in a patient with Wolff-Parkinson-White syndrome. And this is a classic example of Wolff-Parkinson-White syndrome. There's a short PR interval, prolonged QRS wave, with an early slurred upstroke, that's the delta wave, dominant R wave in V1 to V3, ST wave and T wave segment discordant changes. The QRS duration represents the time for ventricular depolarization. Duration is normally between 0.06 to zero point 0.1 second. Q waves are inscribed when the initial QRS vector is directed away from the positive electrode, and the R wave is the first positive deflection of the QRS complex, and its amplitude varies by age, race, and cardiac pathology, and usually increases from V1 to V5. The negative deflection after the R wave is the S wave. So when assessing a QRS complex, you pay attention to its width, height, and morphology. Again, the width, height, and morphology. Now, the width of a QRS complex can be narrow or broad. A narrow QRS complex occurs when the impulse is conducted down the bundle of His and the Purkinje fibers to the ventricles. This results in well-organized synchronized ventricular depolarization. A broad QRS complex occurs if there's an abnormal depolarization sequence. For example, a ventricular ectopic where the impulse spreads slowly across the myocardium from the focus in the ventricle. That means that there's an ectopic beat originating within the ventricles. In contrast, an atrial ectopic results in a narrow QRS complex because it will conduct down the normal conduction system of the heart. In other words, to cut a long story short, in a broad QRS complex, a ventricular ectopic, that is the origin of the impulse is no longer in the SA node, but is somewhere in the ventricles, roughly speaking. And as a result, there's conduction from the focus in the ventricles and thus a broad QRS complex. And a bundle branch block results in a broad QRS complex because the impulse gets to one ventricle rapidly down the intrinsic conduction system, then has to spread slowly across the myocardium to the other ventricle. In other words, remember our diagram from earlier on where the depolarization spreads down the bundle of His through the right and the left bundles across the ventricles. If there's a blockage in one of these ventricles, the impulse, like let's say there's a blockage in the left bundle, the impulse to spread down the bundle of His down the right bundle, go around the ventricles and spread around the left to the left ventricle, thus bypassing the block and also causing a broad QRS complex. I hope you understand. QRS complex may be small or tall. Small complexes are defined as 5 millimeters in the limb leads or 10 millimeters in the chest leads. Tall complexes imply ventricular hypertrophy, although this can be due to body habitus, which can be seen in tall, slim people. Now, the morphology of the waves, the QRS morphology, assess the morphology, that's the delta wave, the Q wave, R wave, S wave, and J wave. The delta wave shows that the ventricles are being activated earlier than normal from a point distant to the AV node. In other words, they are not being activated from the AV node, but from elsewhere. This early activation then spreads slowly across the myocardium, causing the slurred upstroke of the QRS complex. We've already seen that in talking about the Wolff-Parkinson-White syndrome. And I should point out that Wolff-Parkinson-White syndrome is not just diagnosed by a delta wave, it also shows evidence of tachyarrhythmias as well too. And then this is it once again. Isolated Q waves, on the other hand, can be normal. A pathological Q wave is greater than 25% the size of the R wave that follows it, or greater than 2 millimeters in height and 40 millimeters in width, milliseconds in width. A single Q wave is not a cause for concern. That's a single prominent Q wave. Look for Q waves in an entire territory for evidence of previous myocardial infarction. That's an example there. R wave is the tallest wave of the QRS complex. It represents the electrical stimulus as it passes down the ventricles during depolarization. The R wave is progressively increasing in amplitude, moving from the right to the left in precordial leads in the so-called R wave progression, with lead 1 having the smallest and lead 5 having the largest. Now, there are causes of poor R wave progressions. It might be due to an old anterior myocardial infarction, lead misplacement frequently in obese women, left bundle branch block or left anterior fascicular block, left ventricular hypertrophy, Wolff Parkinson White syndrome, dextrocardia, tension pneumothorax, and congenital heart disease. This is a classical example of a normal R wave progression and a poor, as you can see, R wave progression. The electrical impulse is taking time to propagate, hence the very poor progression. S wave. It represents the final depolarization of the Purkinje fibers. It is any downward deflection after the R wave. It may not be present in all ECG waves. It's more significant in V1 and progressively becomes smaller to S wave in V6. Now, in looking at the R and S waves, as we said, we look for R wave progression across the S wave, and then the transition from S being greater than R waves to R being greater than S waves should occur in V3 and V4. Poor progression, i.e. S being greater than R in leads 5 and 6 instead of just 3 and 4, can be a sign of previous myocardial infarction and also seen in large people due to poor lead position. Now, the J point segment is another part of the wave, is where the S wave joins the ST segment. And the key points in assessing the J point segment is usually benign when it's in the age of over 50. It may be raised in a myocardial infarction. And if it's raised in the myocardial infarction, it's also raised, the T waves are also raised as well too. Typically, the J point is raised with widespread ST elevation in multiple territories, which makes ischemia less likely. But if it's over the age of 50, the J point is raised, then there's a suspicion of myocardial ischemia. So that's it again. The QT interval represents the duration from the depolarization to the repolarization of the ventricles. It begins at the onset of the QRS complex and ends at the endpoint of the T wave. The duration of the QT interval varies with heart rate, gender, and age. The QT interval is dependent on the heart rate. A faster heart rate leads to a shorter QT interval, a slower heart rate, a longer QT interval. So the corrected QT interval represents correct for variations in the heart rate. So the corrected QT interval is the interval divided by the square root of the RR interval in seconds when using the Barrett's formula. So in men, it's 0.44 seconds, and in women, it's 0.46 seconds. And then this is the Barrett's formula again. Corrected QTC is equal to the QT interval, the QT to the Q wave to the end of the T wave, divided by the time from 2 consecutive R waves. Short QT intervals are seen in hypercalcemia, hyperthyroidism, hyperkalemia, digitalis toxicity, and that's class 1B drugs. That's drugs for cardiac arrhythmias. Long QT intervals are seen with slow heart rates, myocarditis, hypokalemia, hypocalcemia, myocardial disease, anorexia, congenital heart disease, coronary heart failure, and class 1A and 3 drugs. Long QT intervals increase the risk of ventricular ectopic peaks. Causes are a potential arrhythmogenic mechanism with prolonged QT intervals for ventricular tachycardia, and in particular to tardive pointers, which may lead to sudden cardiac death. That's an example of a long QT interval. Now, the ST segment represents early ventricular repolarization and is usually isoelectric at the same level as the preceding PR interval, as we said earlier. ST elevation is significant when it is greater than 1 millimeters in 2 or more contiguous limb leads, or greater than 2 millimeters in 2 or more chest leads. So once you see elevation in 2 or more contiguous limb leads or 2 or more chest leads, that's significant, and it's usually caused by acute full thickness myocardial infarction. ST depression greater than 0.5 millimeters in greater than 2 or equal to 2 contiguous leads indicates myocardial ischemia. It may be horizontal, upsloping, or downsloping. And this is a diagrammatic example. ST segment abnormalities are seen in acute ischemia, early repolarization, acute pericarditis, ST elevation in all leads except AVR, pulmonary embolism, ST elevation in V1 and AVR, hypothermia, hypertrophic cardiomyopathy, high potassium, acute neurologic events, all leads, acute sympathetic stress, all leads especially V1 and V6, Brugada syndrome, cardiac aneurysm, cardiac contusion, left ventricular hypertrophy, idioventricular rhythm, including paced rhythm. ST segment depression is seen in ischemia. There's reciprocal ST segment depression, left ventricular hypertrophy with strain or depolarization abnormality, digoxin effects, low potassium, low magnesium, heart rate induced changes, and during acute neurologic events. The T wave represents ventricular repolarization. Its morphology is highly susceptible to cardiac and non-cardiac influences, hormonal or neurological. And the suggested criteria for the typical E wave include the size of 1/8 or less than 2/3 of the size of R wave and a height less than 10 millimeters. T wave should be asymmetric in nature, and the second portion should have a steeper decline compared to the first portion. Now, abnormalities in T wave morphology can include inverted, flat, biphasic, or tall-centered T waves. These are examples of variations in T waves. T waves are considered tall if they are greater than 5 millimeters in the limb leads and 10 millimeters in the chest leads. Tall T waves can be associated with hyperkalemia most commonly and hyperacute STEMI. Inverted T waves are normally seen in ischemia, bundle branch blocks, pulmonary embolism, left ventricular hypertrophy, hypertrophic cardiomyopathy, and general illness. The U wave is a small wave that follows the T waves. It presents the delayed repolarization of the papillary muscles of Purkinje fibers and is commonly associated with hypokalemia. Cardiac axis. I should have mentioned this earlier, but here we go. It refers to the general direction of the heart's depolarization wavefront in the frontal plane. The cardiac axis is related to the area of significant muscle bulk within the healthy conducting system. A typical cardiac axis is between -30 to +90 degrees. Of course, a very quick way to estimate the axis, that's a quick way amongst all the rather complicated examples, is by looking at leads 1 and AVF. So the cardiac axis can be defined as the normal axis when the QRS complex is positive in both leads 1 and AVF. Left axis deviation between 0 and -90 degrees is defined as the presence of positive QRS in the lead 1 and negative in the lead AVF. Right axis deviation between +90 and 180 degrees is defined by the presence of a QRS negative in lead 1 and positive in lead AVF. If the both QRS complexes are negatives in leads 1 and AVF, it is termed as an extreme right axis deviation or indeterminate axis. Using leads 1 and AVF, the axis can be calculated to be within one of these 4 quadrants here at a glance. And this figure shows quadrants 0 to -90 degrees. If the axis is in the left quadrant, take your second glance at lead 2. So once again, briefly, both 1 and AVF positive normal, both 1 and AVF negative, axis in the northwest territory. Lead 1 negative and AVF positive, right axis deviation. Lead 1 positive and AVF negative. Lead 2 negative normal axis. And then lead 2 negative when lead 1 and is positive and AVF are negative is the left axis deviation. Sorry, I'll take that again. Lead 1 positive and AVF negative. When the lead 1 is positive and the AVF is negative, look at lead 2. Lead 2 being positive means it's a normal axis. the 3 negative left axis deviation. Causes of right axis deviation is a normal finding in children and tall thin adults. It may be due to right ventricular hypertrophy, chronic lung disease, anterolateral myocardial infarction, left posterior hemiblock, pulmonary embolus, Wolff-Parkinson-White syndrome, atrial septal defect, ventricular septal defect. Left axis deviation. Causes of left axis deviation are as follows. Left anterior hemiblock, Q waves of inferior myocardial infarction, artificial cardiac pacing, emphysema, hyperkalemia, Wolff-Parkinson-White syndrome, right-sided accessory pathway, tricuspid atresia, ostium premium ASD, anteroseptal defect, atrial septal defect, injection of contrast into left coronary artery. Left ventricular hypertrophy is not usually a cause of left axis deviation. And causes of the northwest axis, emphysema, hyperkalemia, lead transposition, lead transposition, artificial cardiac pacing, ventricular tachycardia. So here are some common ECG anomalies. Now the normal sinus rhythm is regular, rate is normal, P wave normal, positive and precedes each QRS. PR interval is normal and QRS is normal. And that's the normal ECG. Arrhythmias. The sinus arrhythmia rhythm is irregular, varying with respiration. The rate is normal and it may increase during inspiration. P wave is normal. PR interval is normal, 0.12 to 0.20 seconds. QRS normal. And then the heart rate frequency increases with inspiration and decreases with expiration. Sinus arrhythmia example. Sinus bradycardia, the rhythm is regular, the rate is typically slow. All other protocols are normal. It may be non-pathological, seen in athletes and seen in people straining to stool. Pathological as in congenital heart disease, age, hypothyroidism, etc. An example of an ECG with sinus bradycardia, you can see the number of squares. Note the number of squares between each R interval. Atrial fibrillation, we saw it earlier, but let's repeat it again. The rhythm is irregular, rates very fast. There's no P wave. The PR interval is absent, and the QRS is normal, but it may be widened if there are conduction delays, usually seen in hypertension, for example, and coronary artery disease. This is an example of atrial fibrillation. You can see there's a lot of irregular waves, and the P waves are usually absent, and the heart rate is very fast. And the difference between each R wave is different. You can see in lead 1, there are 3 boxes between the R waves here. And then in the next R wave interval, there are about approximately 2 boxes or 2.5 boxes, whichever way you look at it. And then in the next interval, there are 3 boxes. Ventricular tachycardia. The rhythm is regular, rate is fast, P wave is absent, because as you know, this cardiac pacemaker is no longer in the atrial, sinoatrial node in this case. PR interval not measurable, and the QRS is wide because of the fact that the pacemaker is no longer in the atrium, it's in the somewhere around the ventricles, and there's, in addition to the depolarization wave traveling down the normal route, is also traveling back, is also backpedaling and depolarizing already depolarized routes, leading to a wide QRS complex. This is an example of ventricular tachycardia. Ventricular fibrillation, the rhythm is highly irregular, rate is unmeasurable, P wave absent, PR interval not measurable, QRS none, ECG tracings in a wavy line. A classic example of ventricular fibrillation. Right and left ventricular hypertrophy. Right ventricular hypertrophy is diagnosed on ECG in the presence of a RS wave ratio of greater than 1 in lead V1 in the absence of other causes, or if the R wave in V1 is greater than 7 millimeters tall. The strain pattern occurs when the right ventricular wall is quite thick and the pressure is high as well. Strain causes ST segment depression and asymmetric T wave inversions in leads V1 to V3. Thus, there's the ST segment depression and asymmetric T waves in V1 to V3. This is an example of right ventricular hypertrophy, right ventricular strain, repolarization abnormality due to right ventricular hypertrophy or dilatation. ST segment and T wave inversions in the leads, which correspond to the right ventricle. The right precordial leads, V1 to 3, often extending out to V4, and the inferior leads, 1, 2, 3, AVF, often most pronounced in leads 2, 3. Rather, this is the most rightward facing lead. Remember our diagrams of leads and the areas it represents. Left ventricular hypertrophy, common presentation, especially in hypertension, is evaluated using several criteria here. There's the Cornell criteria, the modified Cornell, the Framingham criteria, the popular Sokolow-Lyon criteria, and the points-based Romeo-Estes criteria. Now, the Cornell criteria in brief are the R wave in AVL and the S wave in V3, and the sum is greater than 28 millimeters in male or in females, 20 millimeters in females, then ventricular hypertrophy is present. Modified Cornell. Examine the R wave in AVL. If the R wave is greater than 12 millimeters in amplitude, LVH is present. Framingham criteria. R wave in AVL is greater than 11 millimeters. R wave in V4 to V6, which covers the left ventricle, is 25 millimeters. S wave in V1 to V3 greater than 25 millimeters. S V1 or V2 plus greater than 25 millimeters. RV5 or V6 greater than 25 millimeters. R1 plus S3 greater than 25 millimeters. Then the Sokolow-Lyon criteria are the S wave in V1 plus the R wave in V5 or V6. If the sum is greater than 35 millimeters, LVH, left ventricular hypertrophy, is present. Once again, add the S wave in V1 and the R wave in V5 or V6. If the sum is greater than 35 millimeters, left ventricular hypertrophy is present. That's the diagrammatic representation of the Sokolow-Lyon criteria. Romeo-Estes is a point-based system. I will just mention it as a point-based system. It depends on several criteria here. Generally speaking, if the score is greater than 5, depending on these criteria here, left ventricular hypertrophy is present with 83 to 97% specificity. Left ventricular strain pattern is seen ST depression and T wave inversion in lateral leads, i.e. leads 1, AVL, V5, and V6. Then hyperkalemia, electrolytic changes. I chose hyperkalemia as an example. There are other examples, but to keep to time, I just decided to focus on hyperkalemia. Leads 2, V2, and V4 demonstrate tall-tented symmetrical T wave with a narrow base. The P wave remains normal, as does the QRS complex. With moderate potassium overdose, the QRS complex broadens, and the S wave is widening in leads V3 to V6. This S wave becomes continuous with the tented T waves, and eventually the ST segment disappears. Furthermore, the duration of the P wave is increased while the amplitude is decreased. At potassium levels greater than 8.0 milliequivalent per liter, the P wave duration and PR interval duration both increase until the P wave eventually disappears entirely. The QRS complex is diffusely broadened and continuous with the tall tented T wave in all leads. This is a typical example of the hyperkalemia changes: mild, moderate, and severe. And that's hyperkalemia, example ECG. Myocardial infarction, just briefly for time purposes. This is the evolution of myocardial infarction. It starts off normal, then there's an acute with ST elevation. After some hours, there's ST elevation, diminished R wave, and then there's a prominent Q wave. By day 1 to 2, T wave inversion and the Q wave is deeper. Several days later, the ST wave normalized, and now the T wave is inverted. Weeks later, ST and T wave are normal, but the deep Q wave, as we mentioned earlier, persists. And then this is once again a myocardial infarction, showing the ST segment changes in the various indicative leads. Now, finally, here's a brief case presentation. A 53-year-old male presenting with central chest pain for 2 hours ongoing at the time of recording. An ECG is ordered for, among other investigations. Here's the ECG. For time, let's just move to the findings. The rate is 84 beats per minute. The rhythm is regular. There's a normal axis of 75 degrees. The intervals, PR normal 200 milliseconds. QRS normal 100 milliseconds. QT 360 milliseconds. Corrected QT 425 milliseconds. ST segment elevation greater than in the AVR lead. ST depression, horizontal lead, in horizontal lead, 2 AVF B5 and D6. Additionally, there's a T wave inversion in lead B1, flat T V waves in the various leads there.
Sorry, Dr. Thomas.
Yeah.
Sorry, it would have been good before you go to the next slide on interpretation. That would have been good for us to have a look at the image, the
Okay, sorry, I just said it for time.
Yes, I was trying to just keep to time.
Okay. Maybe just for us to just spend a few minutes and so that we can also make it's before you tell us the answer.
Okay.
Okay. So you can go on, sir.
Okay. Anyway, that's it. T flat notching terminal and then RS ratio V2 0.85. Then this is the diagnosis, highly suspicious ECG for posterior myocardial infarction due to a flat right precordial ST depression, prominent R wave in V2, inferolateral ST depression, and the patient, of course, from the history is complaining of acute chest pain. The ECG is a useful tool in diagnosing a wide variety of clinical conditions. Interpreting an ECG requires looking at it sequentially and in combination with clinical signs to get an overall picture. So these are my references, and also they're also put there for further reading. This lecture is by no means very exhaustive. There's a lot of materials on the ECG on the web and on the papers, so these references are put up there for that. Thank you very much for listening.
All right, thank you very much. Thank you very much, Dr. Thomas. It was quite detailed ECG presentation. Let's give a round of applause for him. Well done, well done, well done.
Thank you very much.
Yeah.
Thank you.
One of the very detailed and at least have much required stuff in the presentation that's required for our day-to-day interpretation of ECG. Well done, Dr. Thomas. So we'll now move to the session of questions.
Thank you very much.
And comments, contributions. Okay, there's a question here. Okay, Dr. Lucy asked about the difference between myocardial infarction and myocardial ischemia on ECG.
Okay.
Yeah.
Well, a myocardial infarction may cause an ST segment elevation in the initial phases, while a myocardial ischemia may cause segment depression as well too, and some changes. An infarction is what happens immediately, while ischemia results after the infarction has happened.
Are we okay with that?
Okay. So basically, there's no difference, but that's it.
That's
There's
what is
there's
saying.
no different factions.
Okay.
Hello.
Hello. Yeah.
Yeah.
Yes, sir.
Dr. Maybe let me just make a comment about the ischemia.
Okay, sir.
The infections means that there is an injury, and most of them are shown by ST elevation. Ischemia means that there is deficient oxygen in the myocardium, and most of them are indicated by depression. So we must be mindful of that most of the injuries are ST elevation, and most of the ischemias are depressions.
Yes, sir.
Yeah.
Okay.
And maybe so that I would not come up again. That was a nice presentation. Sorry, I've not been joining this meeting for some time. And the most important thing I want to draw your attention is, as you pick an ECG paper to read, please look at the paper. Look at the rate of movement of that paper.
Yes, sir.
We'll look at the bottom. Normally, it will be 25 millimeters per second. Some people record 50 millimeters per second.
Yes,
and also, if you look at the left ECG before it starts, you will see a strike, like a more of a rectangle strike.
Yes,
and that rectangle, you look at it and you look at whether it is 10 millimeters per millivolt. Some people use 5 millimeters per millivolt. Those are very important. And what you are describing today, especially with the interval, with the height, relates to an ECG paper that moves at 25 millimeters per second. And the strike, that is the millivolt, is 10 millivolt or 10 millimeters. It is very, very important as you handle, even in exams. You should be able to start with that.
Yes, sir.
ECG that moves at 25 millimeters per second, and it has the millivolt, 10 millimeters, so that whatever you want to say will make relevance.
Yes, sir.
Then another important thing I also want to say is that the rhythm leads, because you must understand the rhythm leads.
Okay.
2 leads can be used as rhythm leads. The lead 2 or V1. Those are the most important ones that are used as rhythm leads.
Yes, sir. Yes, sir.
Good. And another thing I also want to draw your attention is the placement of the leads, because it can be asked, you know, have you ever done a lead? What do you do to the patient? So it's important that you must know that which you have actually picked. But the most important is to tell the patient that what is happening. Your heart is like electric. A generator generates this, and you want to pick those activities to be able to look at the heart. And also, you must also be sure that the patient doesn't have any iron on her. All the earrings, everything must be removed. And also, the place that you want to place your leads must be cleaned properly and develop contact with the gel.
Yes, sir.
Then another thing I also want to point out is I'm very happy that you have said something about the rates, irregular and irregularity.
Yes, sir.
And the axis, I'm also very happy that you have said something about the axis deviation, especially lead 2 will determine so many things.
Yes, sir.
Negative will mean that is confirmed, and upward means it's normal, despite that 1 and 3 deviates. So you can use 3 leads, 1, 2, 3, or AVF.
Yes, sir.
Yes. Then another thing I also want to bring out is very, very important, the QTC. Please, every one of you should go and read about prolonged QTCs. Because as a family physician, especially a patient that is at risk of cardiac problem and is having syncope, you must be able to identify prolonged QTC so that you can refer properly, because you need to refer these patients. Those are the patients that have risk, as we have said, of sudden cardiac attack. So it's very, very important that we have to do that. And then another thing, another area I also I've said about the axis. So you should be very clear what you mean by sinus rhythm.
Yes, sir.
Sinus means that the rhythm originates from SA note.
Yes, sir.
Once there is no P wave, it means it's not sinus.
Yes, sir.
Yeah.
So you must understand that.
Yes, sir.
Sinus. And whether it's sinus bradycardia, sinus arrhythmia, and whatever. But sinus, you must understand that sinus means that it's originated from SA node, which is normal.
Yes, sir.
And I'm happy also about the ventricular strain, because most of our patients have hypertension, and you'll be noticing some of those. I think on the whole, I think I'm impressed about that. But I'm just looking at the presentation. Your this thing was interpretation of ECGs. I think that was the topic.
Yes, sir.
Yes, approach to interpretation of ECG.
Approach, good. Yes, it's good that you go into that much detail.
Yes.
But if I were to tell you what is the approach, some of those details may not come in, but it's good for our learning.
Yes.
Because you are going very deep. That's why it takes so long. But all that you have said, I think, is very, very necessary.
Yes.
So thank you very much.
Thank you very much.
Thank you very much. Thank you very much, sir.
Thank you.
We appreciate your contribution, Chief. Thank you
Thank
again.
you.
Thank you, Dr. Thomas. Wonderful presentation again. Thank you for the clarifications.
Nice
Sir,
presentation.
so I think, like Chief has said, most of these things he pointed out, they are really important, especially for those of us going for exams. The junior resident going for exams, ECG, you can't escape it. I know someone that just ECG placement of leads made him come back twice for exam. So it was unfortunate he met the same person twice. And so it can really, it's a really, really important topic. So we should take these things very seriously and go through notes, presentations, and whatever materials we have on ECG to refresh our memories and keep reading ECGs. It's not only when you have maybe a cardiac patient or something, any ECG, fine, try and read and interpret it. It will really help. You get used to it and, pick up these things easily and, any other thing will be, be smooth for you. So, I don't know. Do we have
Sorry,
any...
there's something I just say. Hello?
Yes, sir.
There's something I just remembered now.
Okay.
Most of the ECG are user-friendly.
Yes.
They will give you the interpretation, give you the possible diagnosis. How reliable are they? You should take time to look at it and be sure that they are. And secondly, one of the things is that if there is no irregularity, if it's a sinus rhythm and it's a regular rhythm, there's no arrhythmia, most of those interpretations are right. Yes. A cardiologist from India did a lot of work and found out that once there's a regularity, the regularity is there, the P wave is there, most of the interpretation is right. But having that in mind, it's good to go through those this thing and be sure that they are at least what you are sure or know about. Thank you.
Thank you.
Thank you, sir. Yes, just like Chief said, some of these, most of these ECGs are user-friendly, so you get the diagnosis already written out on the paper. But if you notice, most of our every cardiologist I know will definitely study the ECG separately without even looking at whatever has been interpreted there by the machine. So we should get used to that. And I know a lot of us are already spot with these diagnoses that just pop out. So some of them may not be correct, just like Chief said, especially if it's not a sinus reading. All right. Thank you very much, sir. All right. Do we have any? Okay. Okay, Dr. Akins outlined some. Okay, residents know these points by Chief. Okay, they are common in exam. Okay. Approach the rule of force, PQRST approach, Toronto note. So I hope we are aware of Toronto note, the residents.
Yes. Yes, sir.
I think they have it.
So
Akins posted the current one time.
Yes. Really simplified material to make us understand some of these things better. Okay. All right. So do we have any other contribution before we close the meeting? I think it was a wonderful one. Dr. Thomas, well done. Let's give another round of applause for Dr. T.
Dr.
Thank you
Thomas,
very much.
Very wonderful. Thank you very much.
Yeah.
Thank you very much. Thank you very much.
Chief Lucy, you are training some doctors in the house. Oh.
Dr. Yin. Say good evening, Chief Itama.
Bye-bye. Chief Onyinye, good evening. All right. Thanks, everyone. I think it was a wonderful session today. Let's all have a good night.
Sorry, I'll apologize again for. Sorry, I'd like to apologize again for my video not working.
No problem. Actually. Your wonderful presentation made us forget your videos.
And happy birthday, Dr. Thomas.
Happy birthday, Dr. T.
Thank you very much.
Happy birthday, Dr. Thomas.
Happy birthday, Dr. Thomas.
Thank you very much.
All right. Thank you very much, everyone. Thanks for attending. See you next week, same station, same time. Let's all have a good night.
Same station.
All right.
Same station now.
Same station.
Same time and same station, same network. All right.
Bye.
Bye, everyone. Yeah, bye.
Bye.